All right. For all of those who are here and all those who will watch this online, welcome. This is a brief interview with Dr. Tracey Woodruff for OBGYNs for Sustainable Future. And Tracey, if you don't know, there's about close to 200 OBGYNs on our listserv. Obviously, not everyone can make the webinar, but people do view them. I look at the numbers afterwards. And we are a physician interest group of Healthcare Without Harm.
Oh,
Um,
sure.
yeah, yeah. And so, but let me introduce you. Dr. Tracey Woodruff is the director and endowed professor for program on reproductive health and the environment. She's a professor in the UCSF Department of Obstetrics, Gynecology, and Reproductive Services and the Institute for Health Policy Studies. And she is the director of the Environmental Research and Translation for Health. Her work focuses on uncovering and addressing environmental determinants of disease, health inequities, and how harmful chemicals and pollutants impact health, pregnancy, and child development. She also leads efforts to translate scientific information into actionable change in clinic through public policy and has served as senior scientist and policy advisor for the EPA's Office of Policy. So, Tracey, that was a mouthful. Welcome. We're so excited to have you here.
Well, thank you. And thank you for having me.
Yeah, so what I wanted to be able to provide to our watchers and listeners are some key takeaways for OBGYNs on this topic. We get asked a lot. I see Megan Wolf is here. You might know her. We have formed a coalition of practitioners interested in becoming science communicators about the role of plastics, EDCs, and health.
Mhm.
And so, being able to talk to you and get some answers as we have from Dr. Tresande, just trying to better understand some of the key essential things that we could translate to both our OBGYN colleagues as well as our patients. So in light of that, the reason that I got interested myself on this topic is because I was seeing so many of my patients with hypertensive disorders of pregnancy at rates that I didn't see when I became an OBGYN 22 years ago. The last study I saw had hypertensive disorders of pregnancy complicating maybe around 15 to 16% of pregnancies. Anecdotally, I would say the number's creeping up to 18 to 20. There are times when everyone on my service has some degree of hypertensive disorder of pregnancy. But I'm curious, do you think that I'm seeing something there in terms of a potential environmental exposure leading to these hypertensive disorders?
I guess here's what I think is if you are observing something and it's changing over time in your practice, then I feel like that's a real observation. I think that one of the challenges we have with science I work with clinicians at UCSF is that we need to value these observational findings. That doesn't mean it's like, oh, we have a definitive answer to
Right,
whatever's
right,
going
right. No one
on.
would say that. Yeah.
Right. But it for sure is something that's concerning. And I've heard many clinicians tell me, oh, I see really unusual. You talked about pregnancy hypertension. I had a surgeon the other day seeing, this increase in colon cancer among young patients, which
Mm.
we have that is borne out by the data. And of course, it's not a genetic cause because it has been changing so quickly. And if you can see it over your
Mhm.
practice over the last several decades, that's really concerning. It's interesting you talked about pregnancy hypertension because something that we've been focusing on is gestational diabetes, which has also been going up among pregnant patients. And it's really concerning. And the things that are increasing, since it's not genetics, you're like, well, what is it? It has to be other factors that are external to people. And the thing we're focusing on, or the environmental risk factor we're focusing on, is exposures to these toxic chemicals, plastic related chemicals. They have varying names, but essentially they're chemicals that are made from fossil fuels, and a lot of them are used in plastics.
Yeah. So briefly, for those who might need a refresher, tell us briefly what an endocrine disruptor is, and of the endocrine disruptors that you study, which one are you encountering the most frequently or that worries you the most?
So endocrine disrupting chemicals are essentially exogenous chemicals. These are chemicals that are made that can be found in plastics or everyday products or multiple places, and they're chemicals that can interfere with the levels of hormones in your body. That's simply what an endocrine disrupting chemical is. So, or they're hormone disruptors. People have various names for them, but essentially they interfere with the levels of hormones, and they can do it through a variety of mechanisms. They can directly interfere with binding of receptors. They can influence the degradation or metabolism of hormones. But the bottom line is if you change the hormone levels in the body, which are chemical messengers, and we're really interested in this during development because they're really influential in signaling the different aspects of development. So interrupting development means you're not going to get the right development for whatever it is, whether it's the female reproductive system, the male reproductive system, brain development, cardiovascular system, those can all be interrupted. And those effects may or can be manifest later if it's happening during the prenatal period, happen after birth. So wait, your other question was, which is my favorite
The
one?
yeah, the second one is which is the one you're like seeing all the time, like every day. You can't go a day without seeing that endocrine disruptor.
That's like such a trick question because we see the ones that we study. So, I mean, the thing that's really challenging about this is, I mean, there are ones that are favorites, right? There's like phthalates, which are, and so your audience, I don't know, they're, anyway,
Plasticizer, yeah.
plastic, yeah, they're like a chemical that's used to make chemicals soft and plastic. I mean, they're used in IV bags, right? So that's something that clinicians would be familiar with. So they're used in lots of different plastic applications. They're also used to convey scents or a family of, many, many, many different types of chemicals. And we know that they can disrupt hormone systems. For example, they can uh, uh, reduce the production of testosterone. And that's not very good for sure, during development. So that's one that's pretty common. I just want to pause and say we can talk about my other favorites or ones that we worked on, like bisphenol A and its cousins, or the PFAS chemicals. The challenge about studying this is, as scientists, we tend to study the ones that we know about more and more, but there's thousands of these chemicals. So one of our goals in the work that we do is to identify what we know about. Oh my God, your cat. Okay. Everyone is going to pause now on this podcast to watch your cat walk by.
I mean, it wouldn't be a Zoom without one of my cats.
I'm really a dog person myself. So anyway, so oh, now my husband needs to enter the
I was
room.
gonna say, or a husband.
Oh, thanks. Sorry. Anyway, so I just wanted to say that so I think it's really challenging because, and we've done some of these work with national consortiums of pregnancy cohorts, is that there's a lot of chemicals that we think are actually really also important, but because companies don't have to produce the information to tell us what they're using or where they're using or whether they're harmful, we're just like basically discovering new chemicals to follow all the time.
Yeah, yeah. Here's a question I asked Dr. Trisande, and I tried to ask actually
I see
everyone that I
there is now a chimp in the program.
Ja. But
Oh, focus. Get
It's like
serious.
we
Come
have to
on.
I
I'm
know,
gonna try
right?
and get my dog to come in,
It's
but
it's a literal it's a
they're
literal
not allowed in
carnival.
the room, so.
Um, but one question I like to ask is, uh, I had interviewed him shortly after his phthalate and preterm birth study came out,
Oh,
uh, dem demonstrating potentially 1 in 10 preterm births could be associated with phthalate exposure. What do you say when people say, Tracy, are you guys sure you're not confusing correlation with causation?
oh my
Or
God.
how do
I
you
just
know that?
say, are you from the chemical company? That's what I say. I think you work for the Tobacco Institute. That's what I say. Yeah, let me just be clear. That is a very nice line of argument that is promoted to downplay the risks of environmental chemicals. I was at EPA. I've heard all these arguments. They're like from a same playbook, but let me talk about how we look at evidence, which
Yeah,
is we use what clinicians use. The gold standard of evidence-based decision making is the Cochrane method and
yeah.
grade. I mean, we can debate grade and various aspects of it. But, it's essentially works pretty well. And Cochrane provides a structured, transparent approach to evaluating evidence. And that is a method that we developed a number of years ago to evaluate the environmental health evidence so that we can provide a bottom line rigorous summary of what the evidence says. And it's very clear now that using that we can say definitively whether something is a known reproductive toxicant, a likely reproductive toxicant, or suspected reproductive toxicant. So that's the first thing I want to say is it's not based on correlation, and epidemiology studies for sure look at associations, but there's ways to evaluate the quality of those. And we use a lot of animal data because those are actually
Hmm.
just like a randomized controlled clinical trial for all those correlation equals causation people. And then, and animals are a good, they're an indicator of harm in humans. That being said, so there's good evidence about, I published an article reviewing all the up-to-date systematic reviews and authoritative body reviews on
Yes.
some of these endocrine disrupting chemicals and adverse outcomes. And you know what? We know a lot now, and they are contributing a good portion to the population. EPA did a benefit cost analysis of a new standard related to perfluorinated chemicals. EPA in the Biden administration put out a regulation for perfluorinated chemicals
In
and
drinking water.
in drinking water. And one of the health benefits they included was, and this is from the first systematic review that we did on PFOA, on PFAS, and birth weight, is lower levels of perfluorinated chemicals or higher levels of perfluorinated chemicals lead to lower birth weight babies. And when
Mhm.
EPA did the analysis in their benefit cost analysis, they used that to estimate the number of babies that would be born at a higher birth weight, and resultingly also how many less infant mortalities you would have. And it was
Yeah.
almost 10%. I mean, these aren't, because the reason why it's not like if you're a doctor and you see a patient who has a certain high level of PFAS in their body, it doesn't necessarily mean they're going to have an adverse pregnancy. But when
Right.
everybody is exposed, that means that, some people are going to lose the lottery. Well, lots of people lose the lottery. That was probably a bad one, but they're not, the dice are
Yeah.
not going to roll in their favor. So that's why these chemicals can have such a profound effect. And I think we've really underestimated the extent to which they're impacting health.
Yeah. Well, I will say those comments that I got were one from a colleague in my department, an MFM, and the other was from another MFM. Maybe it's that MFMs don't
Well,
like to hear new
no. Let
information
me
from
actually,
general
what the other
OBGYNs.
thing is, because I think, when you do the training, you got that pyramid. I'm sure you've seen the
Mhm.
pyramid of evidence, and what's the top? It's an RCT, right? And then
Right, of course.
observational studies are like way down at the bottom. And then it's like, well, those are really correlation studies. That's actually not true. And actually grade, just you familiar with grade? Grade, what is
Yeah, great. Yeah.
They've actually redone that pyramid to try and make, I don't know what they call it now, maybe a square, but they have been um adjusting their assessment of these population level studies, these cohort based studies, to upgrade them a little bit to say that it's not a pyramid of RCTs. So that's one challenge with medical school, is that it's kind of taught like, and it's not drugs. We're not talking about drugs. That's the other thing.
Exactly.
It's like you're like based on a um
A
an
pharma
educational
study.
system that's focused on pharmaceuticals, which go through rigorous testing. And the first line of testing in a pharmaceutical study is animal studies. So
Yeah. Yeah.
the reality is that, as you know, that chemicals do not go through multiple tiers of testing. They can't go through randomized controls clinical trials because there's no efficaciousness to them, and that would be unethical. So it's
Just
appropriate to
yeah. Yeah.
rely on animal data, and you already use that for pharmaceutical studies. So my point being is that it's just that the clinical education system is, focused on one area of how to address this and doesn't probably cover the other components of the science. And that's fair, there's a lot, you have to deal with broken bones and things like that. That's, you know, something I don't have to
Um,
deal with in my training. So
Could you tell us and our audience a little bit about the orders of magnitude difference for, let's say, the same amount of exposure? And I know this is a hypothetical, but bear with me. But how is an exposure different in utero versus early infancy versus adulthood? Because what I read is that some of these exposures to these toxicants in utero are having multitudes of orders more effects than, say, obviously in an adult.
Right. So the reason why the prenatal exposures are so important, and I'm sure as clinicians, people appreciate this too, is because those are very unique and rapidly changing developmental systems. And so if you, and I mean, I think, you can think of chemicals like thalidomide, right, as like classic pharmaceutical that women took during pregnancy, and it resulted in severe limb defects, but only if they took it during certain periods of pregnancy. And this was prescribed because for morning
Miscarriage or
sickness.
morning sickness. That's right.
You're thinking of DES.
I always get DEA and
DES.
that one mixed up.
Oh my God,
DES.
DES is really interesting too because yeah, okay, we don't have to talk about it. But anyway, let me just go back to thalidomide. But it's interesting because if you look at it, thalidomide, it's kind of during a particular period when the limbs are forming that disruption occurred, and then you had these, terrible birth defects. So
Right.
it's kind of the same thing with chemicals. Oh, were you gonna say something with
No, that was me. Sorry.
no, no, okay.
I was for some reason I was thinking about folate and neural tube defects, but that's
Oh,
completely related. But
well, I mean, it's probably similar. Actually, it's interesting about folate because I think there's also a period that when you take it, and some people, I have heard some scientists talking about how actually keep taking it is probably not a good idea, that it's
oh
only during a particular period. I haven't followed up on the studies on that, but I
yeah,
think I think it's just like there's key periods where you really need to have that, and then it's less important, or key periods where if it's disturbed, then something permanent can happen. I think the other thing that's really interesting or important about this is that because, for example, in the female, reproductive organs are developing, and they're developing their own reproductive capacity, that if you affect that, like the ovaries, the future eggs, that will pass down to the next generation. So you get this and that has been shown in studies. You can get multi-generational effects. It's been shown in smoking and diethylstilbestrol, the pharmaceutical that was prescribed without testing on many
Yeah.
women. So
So a lot of OBGYNs want to know what like, let's go 3 top exposures to avoid. And these could be consumer choices, assuming that you're not next to a benzene plant or something like that, but like kind of basic things that women in pregnancy should think about.
sure. So I first want to say that we actually put out a set of tips. I don't know if
Yeah, we've looked at
okay.
they look great, but
So I've just put them in there, and we do, even though I am completely 100% against top 10 tips, because it's actually, let me rephrase that. It's hard to choose because there's so many
no, it
things
is hard to
to do.
choose.
But
funny.
of course, I make my own choices, so that was totally hypocritical of me to say that. So I think the things that we like to say that here's things that I think are easy to do and can be done and have been shown to reduce your exposure. So one thing is don't microwave in plastic. Super easy. You can always put it in a plate, even if it comes in a plastic material. So the corollary to that is trying to avoid plastic packaging to the extent possible. And for sure, and the other one, which is something a clinician would recommend anyway, is to eat a diet high in fresh fruits and vegetables and fresh produce, and not to eat packaged or ultra processed or fast food. That's kind of like because there's chemicals in there. We also, there's also if people are choosing fish, there's recommendations about choosing fish that are going to have basically smaller fish so that they're lower in mercury and other types of chemicals. We also recommend you can wash your hands before you eat because chemicals get chemicals love to hang out in dust. So things that reduce dust, like washing your hands, wet mop or microfiber and HEPA filter vacuum. Was that 10?
Yeah.
I don't want to do too many.
No, that's good. That's good. That's good. I just wanted 3, but that's great.
Oh, I know. I said more than 3. See, I couldn't even do it.
Um, you are obviously one of our nation's best resources for this material. Do you see this field moving fast enough to keep up with, or is there sufficient funding? Are there other Tracey Woodruffs from around the country? It seems like for the degree to which these chemicals impact health, that we would have more research focused on this.
Yes, well, there's you, so that's good too, and you guys, all the people on the phone. Um, no, I would say that the amount of research going into understanding the role of environmental chemicals in health is not commensurate for sure with the amount of money we spend on genetics, even though that hasn't really been paying off too much lately. So I would say, I mean, if you look at National Institute for Environmental Health Sciences, which is the main funding source for understanding the role of these growing amount of toxic chemicals in our health, it's a very, I think it's less than maybe 5% or a fraction of the overall NIH budget. And even these initiatives that the Biden administration had said they were going to do, like the Moonshot for Cancer, which was driven by the concern about his son dying of brain cancer, being exposed to open pit burning.
Oh, that's right. Yeah.
I mean, which is a real, there's many, many veterans who have been exposed to toxic chemicals that our country has not treated properly due to that. But that being said, even the moonshot really spent almost nothing on looking at the role of environmental chemicals. So, I mean, I think you're seeing a response to that from the public. The movement around the Make America Healthy Again, um, as I think a response that people feel that it is documented that we're seeing, you talked about it, a hypertension disorder, gestational diabetes,
Obesity.
obesity, metabolic disorders, those are increasing in the population. And the government hasn't done, a lot of the government funding has really focused on individual level risk factors. Oh, you didn't exercise and you didn't eat a right diet, but we know that these are structural factors that are affecting people. And I think people are rightly upset that we don't spend enough money on this. So I'm not saying this administration is going to do that, but it's like clearly indicated that they're rolling back EPA, who would protect us from these chemicals. But I do think, I think people, and we've done public opinion polling, people get the toxic chemicals. They don't want to be exposed to toxic chemicals. They know the corporations are not going to be telling them the truth about them. So I think people want to see the government do something about it.
So are you hopeful then that the MAHA movement will be able to make inroads despite the fact that the petrochemical industry is 20% of GDP? I mean, I see a little bit of a collision there. What do you think happens?
Well, that's a really interesting point, and I like to go back to smoking. Now, I'm not going to smoke myself, and you shouldn't either. But, oh, sorry, I have to say that. But there was a great book. I know this is like fascinating reading, but it was a report of a history of the first Surgeon General's report on smoking, and that's kind
Are
of
we
like
talking like 1954 or what?
1964.
yeah,
64.
1964. But if you read the report on the first Surgeon General and you see how much tobacco was embedded in our society, it's like kind of the same thing. It was like, they were
Oh,
one
wow.
contributors to the GDP in terms of taxes. They had tobacco
Oh,
farms in
yeah.
every state. And you know what turned it around? Scientists saying that this is toxic, and then the public health movement coming out and saying, you know what, we need laws. And really a lot of this too is also around environmental tobacco smoke, that people are like, well, we need to have laws to address this, to tax it, get it out of first it was the airlines, because flight attendants were being exposed, and get it out of workplaces. And
Yeah.
of course, now Zen's making a great comeback on this. But let me just say, smoking is a lot less, and we are better for it. So, yes, I would say that it's a big challenge that we have right now. But I think, we care about it. And clearly, there's a movement of people who are very concerned about this. Now, I'm not sure I don't agree with the focus on vaccines, but I do feel people want to put their energy somewhere because they're frustrated.
Exactly. Yeah. One of your, or part of your work focuses on equity. Can you give us an example of how equity plays out in terms of exposure for pregnant women, whether it's hair relaxers or what would you say? What comes to mind?
Well, I think there's several kinds of equity. So there's where you live equity. So we know
Mhm.
that there are places in the United States that people live, millions of people live, that have higher exposures to air pollution. Maybe they live near factories, or they near polluting facilities, or they live near,
Highways.
freeways, highways. Those are places, and those are low income communities, and they're also Black and Hispanic communities. So those communities are going to be more highly impacted. And I mean, I think if you think of East Palestine, which was a place where there was a
Hmm.
tragic train derailment that led to a lot of toxic chemical exposures, I mean, that is also an environmental justice community because that's a low income community. So these communities have more exposures to these toxic chemicals, and that's really important. I think when clinicians are thinking about people that they're seeing is, just understanding where they live, because that could be an important source of exposure. And then the second part is there are constituents who have higher exposures due to to products that they have in their lives. And I want to say, so like you were talking about hair relaxers or Black beauty products, and or talcum powder. I thought talcum powder is actually a really good example where also you have to be careful because a lot of those are being marketed based on essentially practices that emphasize white beauty standards. So,
Exactly. Yeah.
and that's, and to my mind, kind of predatory marketing that then leads to exposures to products that are more highly toxic. And in the case of talcum powder, we have documents in our UCSF industry documents library from those cases showing that Johnson and Johnson and these other industries were specifically targeting
Targeting.
low-income women and Black women and making them feel like they were basically unclean and that they should use talcum powder. And now, that talcum powder has been associated with increased risk of ovarian cancer. So that's where you can have these different groups who are more susceptible to this type, or not more susceptible, more targeted for this type of marketing, and can have higher exposures. And we've shown in our studies that Black women can have higher exposures to certain types of contaminants that are found in certain beauty products.
Um, just two more questions, because I like to stay on time. What regenerates you, or what are you most excited about in your work right now?
Oh, that's a really trick question given the situation that we are working. I work at a university that's like, and the administration has clearly indicated they don't like universities anymore. So, or research. Let's see. Well, talking to you has been really good. So I feel like, and your friends. Um,
Well, you can
Good.
join us over at PSNAP. Megan,
Yes.
Megan can tell you about us.
I think that it's really important to be, I think the thing that's critical is working with other people who are also understand and are
Right.
enthusiastic about this. But I also play music, so that's helpful too, because you can't do this 24/7, man.
Ooh.
Yeah, no,
What do you
that's cool.
play?
I play keyboard.
Oh,
Cool.
hey.
I'm a big contemporary rock music fan, so there you go. Got to
All
keep
right.
staying somehow. I'm sure you all have hobbies that are really interesting too, so,
Mm.
or you better.
My last question is, do you have a paper coming out soon that we can look forward to, or what a research project that you're working on?
Yes, we do have a couple that we're working on. We have some papers, actually recently papers, and there's one that should be appearing soon, using some of these new in vitro methods to more rapidly identify toxicity of chemicals. One's coming out soon, looking at a number of different pesticides that people are exposed to. We're also doing some work using these like silicone wristbands as passive monitors for pesticide exposure. And we're finding a lot of really interesting or concerning exposures to pesticides. And we're also doing some work expanding our ability to measure different types of environmental chemicals during pregnancy and how that relates to various birth outcomes. So I anticipate some of that will be coming out later this year.
Awesome. Megan, do you want a chance to?
To ask all my grilling questions. Well, I started to speak and didn't realize I had mute on. Tracey, I was going to reach out to you anyway to recruit you. So Jane mentioned PSNAP, which is a group that I've been pulling together. It's a network of physicians and scientists who are addressing plastics and health. And we've been meeting on Fridays, sometimes formally, sometimes informally. The informal roundtables are people like John and Jane and Donna's on this call
And Donna,
too.
yeah.
Yeah, talking about what we're interested in doing, what we're working on, how to find ways to collaborate, pull together, and kind of mesh our social and intellectual capital. You know, if we're siloed, it's really hard to work effectively and efficiently. But there's also like, it's a relief, frankly, to see each other. Like when Jane was asking you, you know, how are you keeping sane? Today is the first day that I wound up dissolving into actual tears over everything going on in the world. And like, this is the happiest I felt today. I'm like, oh, there's
yay.
Jane. There's John. Oh, cool. Tracey Woodruff. Like, that's distracting and exciting to see intellectual peers who are focused on the same stuff. And, you know, some of it's molecular, so that can, I'll escape into the chemistry. But anyway, that's my my shtick for PSNAP. So I'll reach out to you. We can talk about it later.
Okay, great. Yeah.
I want to second that.
Very interested in your. Go ahead.
We had a speaker from Australia. I don't know if you know about his work. Christos Simonides, is that his name? Simeonides.
Yeah.
And it was so inspiring. He gave up a Saturday morning to come and speak to our group on a Friday afternoon. And the work he has done with aromatase, and it's BPA, right? He injected BPA into these mice.
Interesting.
And he's a pediatrician. He works a lot with people on the spectrum, and he's looking at 2 cohorts, I think, of clinical cohorts, and also looking at, sort of combining clinical research with laboratory research. But it was so inspiring to hear him talk, and particularly, I think, because he's not from America.
Yeah, that helps.
Basically, without using the words, basically talking about the precautionary principles. So just talking about how, people challenge, well, how do you know that there's causation? How do you know for sure that there's harm coming from BPA? And he sort of shot back a little bit and said, well, how do we know that any of these things are safe? Which is what you were saying about chemicals. They just don't go through the rigorous testing process and stuff like that they should. So. But yeah, so that made me super happy just to know that this guy had been doing this work. And I really want to, I'm a child and adolescent psychiatrist. My fellowship was at Yale. So I'm really going to reach out to Jamie McPartland, who runs the autism program there, and say, hey, have you heard about this guy? Can you bring him to grand rounds and that kind of stuff? So yeah, it's just good making linkages with people. And Megan has done an amazing job trying to pull some of that stuff together. And
yeah, it's hard though. I know the clinicians, have anybody been watching that show, The Pit? Okay, it's like 9 now. It's about the emergency room, and it's totally like, a million things all happen bad at the same time. But the reality is, healthcare is in a structure where you're not like at the leisure. Your patients are kind of coming all the time, and the training is a certain way. So I just feel like trying to merge public health and clinical health, of course, is a completely important goal. But also it's hard. So
I was wondering if ACOG would even consider doing some sort of technical bulletin.
They have done, actually. We worked with them to do the first one on environmental reproductive health. We did an update to that. I'm hopeful there'll be another one. Now I feel like it's embedded. What do you think, Jane?
Yeah, I mean, I think your update was fantastic. It was absolutely lacking before that. the problem that I see from my OBGYN colleagues is that it is long and it's a committee opinion, and so they don't maybe tend to read it. And that's why at PSNAP we're working on just a one-pager. Because and even like your handout that you posted, I think is 3 or maybe 4 pages.
We have a one-page version.
Oh, you have a one-page version. Yeah, so we were gonna do that and have it be sort of branded by PSNAP so that we can get some of our new logo out there. And you know, and we at PSNAP are for the most part a lot of pediatricians and one OBGYN so far. Yeah, I think that clinicians need something that they can apprehend quickly, because what I see, I admin a group of 7,000 OBGYNs on Facebook. And what I see is that people are overwhelmed by the information. And so they're not yet at the point of being able to translate the science for their patients. They're barely kind of able to apprehend it for themselves. And we need to get them so that it's part of their anticipatory guidance, you know, where it just flies off their tongue really fast.
Have you had Maria Zlatnik on your show? Do you know her?
No, I do. I know her from social, but I've never met her.
Oh, you should totally have her. She actually sees a patient, so, or more than one patient at a time. She sees patients, and she's part of the pediatric environmental health specialty unit here at UCSF, so she's very familiar with giving out, or how she gives out information to patients. So she might be really good. She's also on the Children's Health Protection Advisory Committee for EPA. Does that exist anymore? I can't tell you or not, but she was on it, if it still exists. I haven't looked on their website. But she would be an excellent.
What's the name again, Tracy? This is Donna.
Zlatnik, Zlatnik, and she's at UCSF in the MFM division.
Thanks.
Yeah,
and she is on social. So
yeah, we see each other on social a lot. I'll reach out to her. She'd be great to interview.
Yeah, she would be excellent.
I have a general question that I think it'd be interesting to hear Tracy's comment on, and then also the rest of you. What about, so the tendency as we come to new epidemiological understandings about environmental health, the tendency is always from the tobacco playbook to try to turn it back onto the individual, right? So, you know, we got out of it because of secondhand smoke with tobacco, but as we manage to demonstrate the links between plastics and endocrine disruption, what about what we can anticipate? There's going to be a fair amount of people saying, hey, you're fat because you drank out of a plastic bottle. That's why you have diabetes. That's why your kid has autism. That, you know, your mom got dementia from all the microplastics and EDCs that she picked up because she ate off of plastic dishware. It's her fault. Just anticipating that coming along, like, what are your thoughts about strategy from what we know in the past and what we know now about this science? How are we going to deal with that?
That is an excellent question. So I think what we have been doing, or where we are focusing now, is looking at how does the industry playbook propagate across different industries? So I don't know if you guys know, but UCSF is home to the Industry Documents Library. It's the largest archive of internal both tobacco and other industry documents. So it has tobacco. We're receiving the opioid documents from the opioid cases, a Juul case, sugar, ultra-processed food, some fossil fuel, and chemical documents. And what we've done is started to work with faculty across the UCSF campus and outside. And we started a new Center to End Corporate Harm, because we need to have the health community recognize that corporations are really the leading producer of health, of the biggest contributors to chronic disease globally. I mean, if you look globally, the biggest burden of disease now is chronic diseases. And that has shifted dramatically over the last 20 years. So our work is to illuminate that, because the public, and if we use a lot of industry documents research to show how the industry, in their own words, what they do to hide the health harms of their products. And then that helps fold into, we work with, people in the policy space to hold the industry accountable in that situation.
Amazing. Yeah, that's fantastic. I was thinking about alcohol as well. I mean, all the beverage.
Alcohol, yes. And the tobacco industry works with the alcohol industry.
Yeah.
And so
You can look at on a can of beer now, and there is a warning that alcohol increases risk of various cancers, breast cancer, blah, blah, blah. But it's almost impossible to read. 'Cause it's the
at
same
least it's
color.
there.
It's the same color as the aluminum on the can, it's like,
Well,
yeah,
it's
and I
so
think
interesting.
there's
Oh,
a big public health push now to identify all the deaths that have occurred from alcohol use. I mean, not
Right.
just like severe chronic alcoholism, but much lower levels of consumption. And, these international papers that have said they're really unable to agree that there's any safe level of alcohol intake, which
Yes.
pretty mind-blowing when you think about it. But, you don't see any of that in terms of what we're exposed to in America because the beverage companies have a lot of power.
Oh my gosh, right?
Right. And so part of it, we have actually have a set of recommendations about how the government can do better decision making. And one is all on science integrity. And I think alcohol is a perfect example of how the alcohol industry, they funded NIH studies, they appeared on, IOM reports. I mean, they really had a lot of influence and they were totally promoting this line that it's moderate drinking, even and then I
Oh,
mean,
yeah.
it's so funny when you go to these meetings. I was like, how do we know that alcohol is so dangerous now? And I'm like, because the alcohol industry's people finally unearthed the fact that they were influencing that research base. I think you're right. There's no safe level of alcohol. Does that mean I'm never going to have a drink? No, but at least you know what the risks and benefits are.
Yeah.
It's not, so I
What an amazing institution you're working in, though, that they have all these things that they've set up. That's amazing.
It is. Now, I hope that it remains amazing because
Oh, yeah,
there's
right.
a lot of efforts now
Oh,
to
yeah.
undermine all that work.
They're gonna be gone, but they'll come back.
Yeah, I hope so.
Tracy, which of the tobacco histories were you talking about earlier? You were
Oh,
saying
let
you're
me
referencing.
see. Yes, let me find that. It's one of the things I keep. It's called the Oral History of the Surgeon General's 1964 report, and it was published by UC Medical Humanities Press book series. Oh, here, I'll put the link in the chat. And in it, it has a graph of the increase. It has all the information about the just how ubiquitous tobacco was in the as like embedded in our economy.
Mm-hmm.
So
Cool. Oh wait, so that's Clearing the Air, the Untold History.
yes, if you go
Okay,
down
cool.
farther in there, I mean, it's a little wonky, but you should do a podcast with these people. It's super interesting because I know you're not supposed to do this, but they met in secret because they were freaking scared about the tobacco industry. I think they actually had put somebody from the tobacco industry on the panel because they're trying to make it look balanced, but the evidence was, I mean, in this case, obviously the evidence was super clear. But I think the other thing that's super interesting about the 1964 Surgeon General's report is, how everyone loves to talk about Bradford Hill and the Bradford Hill criteria.
Yeah.
Yes. Well, it actually really was first in the 1964 Surgeon General's report. So Bradford Hill really plagiarized them. But anyway.
Really?
Yeah, he's dead now, so I guess we can't go after him. But I'm kidding. But it was all those factors that you look to evaluate the strength of evidence are published in the 1964 Surgeon General's report. So, I mean, they all may make sense. It's not like
Right.
not to take anything away from him, but it's sort of funny.
Awesome. Wow, we have taken up more of your time than I told you. So thank you so much for staying with us and answering all these questions. I am going to stop recording. There we go.